Good morning to all my uh, international guests, national guest faculty, as well as participants and the industry friends. With me is Dr. Sanjay Shah as usual and Professor Akasaka, the world guru on imaging and physiology. He is going to be an on-site moderator, and this is the time when we we will start our first master class on physiology and imaging. It reminds me the old days, like I started the radial program with Sanjay and my crew way back in year 2000 at Krishna Heart Institute with the help of Dr. Shigeru Saito of Japan, and eventually it became one of a strong radial program. And in year 2005 we did an humble attempt to educate the transradial technique to the young generation of this country, and then subsequently the young generation of surrounding country and the world. And we started the initiative of TRICO. TRICO 2005 was the first TRICO. It was a transradial intervention course. It started as an humble attempt or an initiative which subsequently became a movement across the board in the country, and then subsequently in US and everywhere, and now it has become almost like a way of life for most of the interventional cath labs and many of the interventional cardiologists in their day-to-day practice. And we feel really gratified that we have contributed to something. And this again gave us this idea to start this master class, which I was toying with Sanjay and Samir Pancholy, and ultimately we thought to put it in practice that everybody is interested in doing, performing the imaging modality or physiology. And many of the young cardiologists are doing it also in the country and even in the surrounding countries. But it is a hard fact and it is an unfortunate fact that most of them are dependent on the interpretation done by the company person. And the judgment is being taken on the basis of that. Company persons are very expert in interpreting the image, but one has to interpret the image and then correlate it clinically in an overall perspective to offer the best of the outcome. And for that, an operator has to be an interpreter to an extent. So with this concept, we are again starting this initiative of teaching and learning physiology and imaging. This is going to be a purely academic time for 1.5 days, where we will be exchanging our thought processes, doing live cases, and then with some great talks and panel discussion and lot of interaction amongst each other with international guests and national guests. So this is what is all about it. So we start, and this the first case is a patient, a middle-aged patient with who presented with unstable angina and hypertensive, and his angiogram revealed a very heavily calcific LAD lesion, and the distal RCA, which is quite distal, syntax score is 9. And here we are planning left anterior descending artery stenting. The plan is to dilate the lesion with a non-compliant balloon, and here After dilating, if all is well, I will perform one IVUS run and one OCT run, and we will have some discussion on it. I personally feel that this case will qualify for intracoronary lithotripsy. And if it qualifies for intracoronary lithotripsy, we will do intracoronary lithotripsy, and again we will take one OCT run and we will have discussion, and then we will go ahead with stenting the area, and then the end result will be evaluated. Now I am throwing this session open for discussion. Samir and Abhiram are there. My friend Rajesh and Pintu, everybody is there. Jayesh.
Yes, good morning.
Ankush, good morning. Yeah.
Good morning, sir.
Good morning.
So Tejas is Abhiram. So the LED lesion is looks like a bifurcation. Can you tell us more? It's hard to say from here if it's a true bifurcation or not.
Actually, yeah. But Abhiram, the origin of diagonal is quite clean. So bifurcation and with a clean diagonal, I am never worried about the side branch, sacrifice. 99.9% of the time it doesn't happen. So, but I will take few more views and we will come to the conclusion. Yeah, so I am in with EBU 3.5. Go to AP cranial, AP caudal first.
Dr. Tejas, good morning. Rajesh on this side.
Yeah, good morning Rajesh. How are you?
I'm fine, thank you. So, Dr. Tejas, as you rightly mentioned, we at some time has attended your meeting TRICO since 2002, 2005. This is a conventional transradial approach. When are you going to start with the distal radial approach?
Distal radial I have done 1,000 cases and now we are doing very sparingly, Rajesh. Only when obese person with the left radial we have to do because it gives comfort to the patient. And otherwise we don't.
Okay, and what's your experience about radial occlusion, conventional radial versus distal radial?
See,
any advantage?
That's a great question. I mean, distal radial does not touch the real radial area.
Yes.
So intuitively, the radial artery occlusion chances are less. You have a world authority on radial artery occlusion sitting on the panel. And Samir can answer that at length. Go to areocranial. Samir.
Hi Tejas, good morning.
Yeah, good
how
morning.
are you?
Good,
Sanjay,
good.
Aman, how are you? Looks like a very typical, difficult case.
Samir, Rajesh Vijayvergiya, my friend, professor at PCI Chandigarh, asked that question which you should answer. Distal radial versus regular traditional radial, the radial artery occlusion rate. What is your view?
So if you look at the literature so far, the distal radial has been shown to have lower occlusion rates, but you have to factor in the fact that distal radial also has a very sizable conversion rate. So you want to do distal radial, but you cannot do it. And is it an effect that the distal radials which allow you to get in are the larger distal radial arteries and hence less occlusion? Remains to be answered. So in a rote sense, yes, distal radial has lower occlusion rates. But I think it's more complicated than just that.
Abhiram, you can see that the diagonal somehow, now I want to ask Professor Akasaka about this calcific lesion. Somehow, I don't know, but it gives me an intuitive feeling that we may confront with a nodule. I am not sure. Professor, what do you think about this lesion?
Yeah, by angio it might be very difficult to answer correctly, but there are lots of calcium from proximal LAD to the mid LAD. There are two tight lesions, and just before the diagonal branch, we can identify the very eccentric and
2.5
very tight lesion.
NC image.
And at that
50.
site, the calcium is not so clear, but I think the patient is not an unstable condition. Therefore, we speculate a nodular calcium, not a calcified nodule. That means non-elapsed.
Okay.
Yeah.
Okay.
Dr. Samir, what's your opinion regarding that disco radial trial that just came? Because that, that negated our previous, evidence that whenever we use distal radial, that radial artery occlusion rate is, significantly lower as compared to.
But radial artery occlusion is low if you take good care of the regular radial by using the patent hemostasis technique.
That is true. And I think, talking specifically about disco radial, Ankush, is, in disco radial, the trial was marred by the fact that their event rates were very low. So their sample size calculation was based on a completely different, set of numbers. And so in my eye, there was a trial that I cannot use negatively or positively.
Two.
But one thing that we usually find that at our center we do distal radial quite common. The pain factor, the patient comfort factor, that's quite, for patient it's very comfortable. This is what we have observed.
નથી ગયું જો તો
Yes, sir.
This is an NC emerge 2.5. I underestimated the complexity of the lesion. At NC emerge I am doing some jackhammering, but it struggles to go in. Scout, what will you do? Go to AP caudal. Scout.
Sir, good morning. Dr. Nahata here.
Good morning.
Sir.
Good morning, Professor.
Sir,
Tell
can
me.
we take small balloon calcified lesion?
Yeah, that's what I will do.
Tortuous.
That I will do. I am just trying to deep intubate my guide in the proximal LAD. Give a chance there. Just see. No, it refuses to go. No problem. Get me 2 millimeter. NC emerge. Yeah. Wire. Go to AP cranial. Let me set the wire right.
Good morning, Tejas.
Good
Just
morning.
I want to ask, suppose we are going for a calcific lesion, we are going for rotablation. Suppose patient got a 360 calcium and long,
Give
and
2 cc dilsium. Yeah, go ahead.
then why to take a 2.5 mm balloon? Why not to take a small balloon if you plan for imaging and later on with the rotablation?
Good question. Good question. I thought that I want to do intracoronary lithotripsy. I can open it up and do it. And that's why I took a bigger balloon, because lithotripsy balloon is a bit high, bulky balloon. अरे भाई dilsium आपो. काड़ो भाई की तकलीफ छे? आहा.
So Rajesh,
Balloon.
Tejas, just to be devil's advocate, this is the sort of lesion where rotablation,
Gone?
rotablation may be
Scout.
a good idea up front
Yes.
for
Yeah.
these very reasons.
Go here. I think we will dilate this area 15, 20. Bhai, covered stent રાખજો અહીંયા. Deflect.
20.
Deflect.
Went further.
It did go further, yes.
Go.
It's
Go.
slowly going.
Go up. I am continuing jackhammering
20.
in this area. I think we are there. 18, 20. Deflect. હા આપો ભાઈ. Dilsium બીજું આપો. ટેકી થશે અમન જાઓ ગો અપ હિયર સબલિંગ્વલ નિફિડિપિન આપી દે
20.
ડિફ્લેટ ચાલો inject and see
Take advantage.
patient has become hypertensive.
Okay.
I am trying to settle it. Still down.
થોડુંક ડાઉન એક આપી દઈએ.
Scout.
હજુ
Yeah.
set little.
Go.
Good progress with this balloon.
Yeah. This is NC emerge. I love it.
What's the length on this?
12.
12. Okay, so I think it looks like the length made the difference, right?
But 2.5 was, I think, a bit more bulky.
plus
Scout.
અહીંયા
Ah.
વધારે
Scout.
પડતું છે. Set push.
Yeah.
Okay.
Go here.
ગયું.
I am trying to prepare a bed.
20.
Deflect. Wait. Now come back and dilate. We simply go on dilating.
20.
Deflect. નથી ખુલ્યું.
Dr.
Copy
Tejas, at what point that
Go.
after this dilatation you will decide that you may go for rotablation? Just
I will now I will be upsizing my balloon first
Okay.
and prepare a proper bed and then we will see. I'll let you know. એમને સેજ સુવાડી દો રજનીન કો ડિફ્લે કરવા સુવાડ દેવા આપવું જ કઈ
ના
ચાલશે
ના રહેવા
રહેવા દો
બધું હલાવશે બધું.
હા ચાલો ચેક ઇટ
ચલો. ફાઇન.
ઓકે
લઈ લે bigger size.
2.5 Samir, this case I think the lesion was much more resilient than what I thought
Yeah,
because of the tortuosity, I think.
true. And I think the important thing I saw in the last picture is the diagonal ostium is still very preserved.
That I am reasonably confident about.
True, absolutely, yep.
See, only where this diagonal can give me problem is if there is a calcific flap and the part of it, is streaming to, going towards, flipping towards that area, then it can give some problem. But let me
That's
see.
true.
We'll work it out.
Now, once we dilate it up and everything, would you prophylactically, wire it and place a wire?
I will like to keep it as simple as possible. Go here,
No, little more if it goes.
but I think
Okay.
we can dilate here.
Fine.
This area is the toughest area. Here we will see waist, I think. I am doing a short scene here. Deflate. It's open. ભાઈ એનો હાથ નીચે કરો. એક જણ ત્યાં રહેજો ભાઈ. See, it fails to move in.
વચ્ચે આપી દઈએ.
Give here also. Deflect.
I think that sinusoidal type curve there is where the
Yeah, it's
resistance
giving me
is.
problem.
In such kind of lesion, which calcium modifying is better, rota or orbital or IVL?
Rota can be a complication prone treatment in this situation, I think, Jayesh.
આપી દઈએ.
Yeah,
I'm pretty sure there's going to be 360 calcium here.
absolutely, absolutely.
So, IVL probably will do the best.
That's
job.
right.
That Tejas, in case we are not planning for rota or orbital, can we put a wire across the diagonal
more.
because it's a very big branch?
Because the diagonal, Rajesh, is pretty normal. And by putting a wire, I will be, obstructing my devices to go in because intermingling and other problems will be much more. You can see the struggle I am having even with the simple one wire.
But only in this case will
Yes,
proximal
go.
lesion can be treated with rota, just to make the facilitate half rota.
This is open now.
20.
Huh? This looks better.
Imaging is
I think this is where, once we have the the
Record,
lumen
inject
straightened
curve,
out a little,
inject curve.
imaging will be of big help. Everything will become easier to decide.
Looks good, nah? Now we are in the command of the situation. Now I am 99% sure that nothing will go wrong to that diagonal.
Yep.
Go up
Looks
here
great.
again. Let us dilate it. Record and deflate.
Something that you said was very important is that you could put a wire in the diagonal. It might even work as a
Go.
buddy wire or anchor wire, but the intermingling and the twirling is also equally detrimental.
And in the middle of complex procedure, to take care of all those things. See, even I have to take care of the tip of the guide catheter here. As I pull my balloon, the guide catheter has a tendency to suck. All these things. So I have to be extra careful.
It's true. Keep
Go.
it simple.
Deflate.
I think we just dilated that knuckle
I think
there.
this looks better. I will not be very easily satisfied with this dilatation. I will pull my balloon inside the guide catheter and try to push it again and see how easily or with difficulty it goes. See, this it has a difficulty again. You can see that. Scout. So what next?
It's probably a good time to do some imaging, I think, before it modifies so much that it may not add much to your...
Because I am pretty sure that it's not easy for the IVL catheter to enter in.
Yes,
Agreed.
I don't think
If this
IVL will-
balloon does not go.
Do you think that OCT catheter will go or IVUS catheter will go?
IVUS or OCT will certainly go because I don't see much problem there. OCT, if there is a nodule, big nodule, then OCT catheter is a little delicate catheter. It can give me some problem.
One other question. Any role of exchanging the wire for a wiggle wire or something more
Oh,
supportive?
Samir, that will make the things even little complex at this point of time. I will try to make it easy by putting a guideliner and going in rather than this thing. But let me see.
I think that proximal lesion, that proximal to LAD, that will be helped by putting another wire. That will give us a good, buddy wire effect, and it will give us a, poor man's.
Buddy
cutting
wire, Ankush, buddy wire can work very well in certain situation where there is a moderate, up to moderate calcium, but with severe calcium, there will be lot of wire bias with the balloon and the device which you use on your regular wire. That is a major problem. Let me take an opinion of a wise man. Sanjay can opine. What to do, Sanjay?
No, we can introduce another balloon because this is already profile has lost.
Yeah,
because of
it has
multiple
lost its
dilatation.
profile.
We can
So
take
that is a
another
good
balloon.
idea. So will we take a 3 millimeter balloon or yeah?
3 millimeter.
Get me a 3 millimeter
Short.
short. Yeah.
Dr. Tejas, is there any dissection distal to the diagonal in the LAD following balloon dilatation?
Yeah, it's a big calcified area, has given a good dissection, and that dissection keeps me happy because then we have opened it up well and we have done a lot of macro fractures in that region. 8 or 12? 8.
So we'll do imaging after dilatation.
Yeah. I want a very clean track before imaging because during imaging I don't want any issues.
Is there any option of, say, using scoring a cutting balloon over here now?
It won't, Rajesh, I think
For that, I think we need
it
a
will be
guideline.
difficult to push the cutting balloon in. It's a
Bulk.
stiff device.
The curves are more than they appear angiographically.
Yes,
Yeah, much
yes,
more,
Samir,
yeah.
you said it.
Now this is a run-through wire.
Yeah, run through extra floppy. That is the workhorse wire in my lab.
Yep. It has a good habit of making that loop which you can bury in the apex.
Yeah, that's right.
Yeah.
Scout. But it should not be taken very lightly.
True.
Yeah. This tip can perforate.
Yes.
And that's the reason when I am working in LED, I like to park my wire properly, not very distally, or if at all distally, I will try and find one septal and when I park it, not any diagonal or even in a regular distal LED.
It's true.
Deflate.
Is that an 8 millimeter?
Yeah, that's right. Deflate.
It's expanding fairly well.
Yeah, that's expanding very well. Go. I don't like the guide catheter movement actually.
But I
Deflate.
think this is the typical example of angiographically looking expanding, but actually there is not a significant luminal gain with these kind of lesions.
There's usually a lot of recoil, right? So, yeah.
Deflate. Go in. Now, મને એવું લાગે છે કે we should જો તો સ્કાઉટ કરીને જોઈ લે inject. Okay. There is some wire bias also in that region. I think we have done a good job on it. Now, give me.
Proximal આપી દેવું છે?
Yeah, go to epicaudal. Epicaudal.
Regarding the
I will take one IVUS run followed by one OCT run here.
એક મિનિટ આ બંધ કરો.
Sorry.
Yeah. Regarding the diagonal, I think it's a very, it's a
બરાબર
little bit difficult to rewire the angle. Suppose it closes, then now at this stage you will.
Yeah, I tell you, when you are working on a highway, Jayesh, at times you have to ignore certain things about the small roads. It is not a very small road, I know, but I have burnt my fingers doing this in last 30 years sometimes. But yeah, everybody has a different experience and I am very open. But I will not wire because of whatever reason. I have a very strong feeling that nothing will go wrong. Let us see. Okay. So first I will take an IVUS run, then OCT run. And then Professor Akasaka will interpret
Tejas,
with us.
do you prefer 7 French in such complicated cases or 6 French?
6 French by and large. Only when I am working on an extremely complex left main bifurcation where I decide that I have to go with 2 stent strategy, then I will use a 7 French, not otherwise.
And going back to that original question about orbital versus rotor, that's the thing, so if you start with 6, I think one of the nice things about orbital is you can do that through 6. So,
even in the bifurcation 6 French, you can use the IVUS and OCT catheter with 2 wires in?
No, not 2 together, one by one.
But I think what you were asking is
Yeah,
2
wires
wires
and
and put
6 French
IVUS
guide.
catheter.
Yeah.
You
Of
can do
course,
it.
yes.
You
yeah.
can do it, yeah.
Go to epicranial.
Because suppose you have thrombosection, it is not easy to do that.
That is true. Especially with the export catheter,
A septal
it
maja?
doesn't go with the second wire.
It's moving, yeah.
Yes, moving.
I think it has taken the second curve. I think let's just check it out. Wait, Scout. You think
Almost
okay?
We are there. No, but we need to 10 millimeter more.
10 millimeter. Sanjay, that makes my life difficult, but let me try. Go to epicaudal. Somehow the guide catheter is not as supportive. Scout. Yeah. Now go to epicranial.
I think it's almost an unfolded ascending, the pseudo-Lusoria type
Yeah.
pattern.
It's okay. એક આ જોઈ લો ઇન્જેક્ટ કરીને જોઈ લો let's inject.
At least proximal we will be able to see.
Yeah, at least we are after that diagonal significantly in the lesion.
Only distal lesion remained.
The distal lesion remains, but it's okay. Let us check it. Let's check it. So coaxial. Guide catheter is outside. No problem. Nah.
Okay.
Yeah, go ahead. Professor Akasaka
Okay, yes.
will interpret even
Yeah.
IVUS image as well. Yeah.
Yeah. Oh, stop.
Yeah.
Yes. A catheter is just proximal to the distal region. You can identify the calcium, the 12 o'clock, and here we have a lot of calcium, just 12 o'clock, and this might be the branch that, yeah, okay. And also you can identify the severe calcium. We cannot identify anything just behind the calcium, right? And also nearly circular calcium here, except for 3 o'clock. It's an septal branch, and also the severe calcium from 12 o'clock to the 9 o'clock. Yeah, heavily calcified region. And also this might be the branch, and also nearly 270-degree calcium. Yes, but the calcium is the very superficial. Okay, still calcium in the yes, 3 o'clock. And big branch here might be the diagonal, I'm not sure. Might be, yes. Right.
Okay. Okay. We are out, huh?
Okay.
So I am removing it.
Can we review, right?
Oh, it jumped in.
मैंने push कर दिया.
Go to AP caudal, please. Give me OCT catheter. Just check the coaxiality.
Dr. Akasaka, this
yes.
is Samir. So in this case, with this much information, how would you size your vessel? With
Vessel, yes. We have to check the proximal reference, right? Okay.
Yep.
Here might be the proximal reference. Okay. Now the measuring size is around 4.5 in the proximal site in the lumen, right? So it is the lumen size, right? More than 4.5. Yeah. No, please to move to the distal portion. Here we have the calcium, right? So we cannot identify in the distal site because the catheter is just proximal to the distal stenosis, right?
Right.
So here we can identify as a media, right? In the some portion.
True.
In this portion, media to media is 4.28. Yes. So the very big artery, right?
It is a very big artery, and I think
No. Just see this, this OCT catheter is not going in. In this case, I will not do too much with this, and I will straight away take the IVL catheter and try to make the things better.
Sure.
And then I will do an OCT. Okay, out. We take a 3 millimeter.
Dr. Akasaka, any
3.
comment about fracture of the calcified lesion 1, and second thing, plaque characteristic was the origin of the diagonal.
Right. Generally speaking, plaque should be a very high echogenic, so that might be the fibrous and also the lots of calcium. I cannot identify any nodular calcium because yes, this is in a very tight region. Can you see
yes, we
yes,
can
yes, nearly 300-degree calcium, right? Yes. And some part, yes, the balloon make some dissection at the end of the calcium, right?
Yes.
6 o'clock and 7 o'clock, right?
Yes, we see it there. We can see the gap.
Yeah.
Now, what size IVL balloon would you recommend based on the sizing?
I think the IVL balloon is very bulky, and I'm just wondering it might be close or not because OCT catheter does not close, right?
You think a 3 millimeter to start? Or
Yeah, 3 millimeter, yes.
3 millimeter to start?
Yeah, because the size of the vessel is very large, right?
So, while we are trying to deliver, quick question. When we measured it, it was 4.28, and then we are going with a 3 millimeter balloon. And why the downsizing?
OCT 25 करिए,
I have not enough experience about the.
जो अंदर नाखी दिए तो जाए तो.
But they say that as far as IVL is concerned, we have to go 1:1. Like for IVL to be contact with the lesion.
312.
The dia coming is 2.5 to 3. I think 3 would be effective to start with.
So that the 3.27 measurement is distal, right?
Yeah, distal, yes.
So we are sizing it to the distal EEL diameter. We are downsizing by a quarter.
A quarter, yes.
And
I have used a guideliner, Samir.
Yes.
And I am using now IVL catheter. Once I do lithotripsy, I will use
OCT.
OCT, yes.
That's great. I think that's a good idea. Yeah, I was just trying to clarify the size choices, and so we are going still by the algorithm, which is the distal reference diameter with EEL, and then quarter size down. Even though in the middle of the artery where the lesion is, it's 4.5 millimeter vessel.
Yeah, generally speaking, as you said, yes, if we can identify the EEL, the quarter size down, and if we cannot identify the EEL, and at that time we try to use an lumen, right?
Yes.
And at that time, quarter size bigger
Up,
is the
yes.
idea,
Exactly.
yes.
Thank you. That's great. Yep.
So, Sanjay has already prepared the lithotripsy catheter. I am taking 3/12. Here also there will be some discussion whether 3/12 or 3.5/12. But yeah.
I think, the distal reference is 3.27.
So yes, then 3 is
good,
perfect.
yeah,
Yes.
Exactly. And the lesion lumen diameter is much smaller than 3.
So my question to you is, what are my chances of pushing in this catheter?
Did you give it the banana shape?
No, not in this case. With this thing,
I think it will fight itself through with the guideliner.
it will still make me struggle.
It will. It definitely will. But I think the guideliner is going to help.
Yes.
There you go.
Yeah,
you're through.
This
already.
is good. Go to AP cranial.
I think
Little more.
the one other thing to point out is the dynamic of guide support from right radial.
Go from here.
It's coming
I
from the
don't
sinus
see
of
the blood
Valsalva.
चालू करो.
Blood pressure not देखा.
That is okay.
चल. 10 pulses. Second case લગાડવાનું કહી દો. ધીરે રહીને 5-1 મિનિટ રહી.
6.
Okay, let me come back.
So you are planning to give one cycle each?
Yeah, and the area where I find maximum resistance, I may give a couple of cycles there. Now I have to do it everything blindly, but good thing about it, Ankush, is, it is expanding very well.
Yes, sir.
And when this balloon expands, anything can go in.
Yes.
That I am for sure.
The IVL balloon, once it is expanded, how we can come to know whether a pulse is effective or required at that place?
We have already, Jayesh, taken, go ahead. We have already taken the IVUS run, which already shows that is a humongous. See, the thickness of calcium I could have shown you on OCT, which my catheter refused to enter. At times it happens. So that I will show. Okay. Guideliner is too much in.
So they say that for IVL to be effective, it should be in contact with the lesion. And
Okay.
yeah.
distal wire.
No. So IVL balloon is not a for dilatation. It's an application balloon. You just take the balloon dilated at 4 atmosphere to apply those 50 atmospheric, pulses.
Deflate.
So it's only an application balloon.
Record.
So Dr. Tejas, what is your, experience of IVL with calcified nodule?
Pardon?
Sir.
Calcified nodule is a malignant condition. During these 1.5 days, we have a lot to discuss amongst ourselves and with Professor Akasaka, who has highest experience. Calcific nodule is a malignancy inside the coronary, I personally feel.
Exactly. So I was asking, what is your experience regarding impact of IVL on calcified nodule?
I don't think it works so well if it is calcific nodule is very big, because IVL will distribute the pulses in 360 region. If you have an IVL modality which you can direct it selectively to certain area, then it can work. Many times it does not work. And nothing works many times. Yeah. Give.
Yeah, I think, there is still some under expansion there, right? Yeah.
Yeah, we are giving another one there.
Yeah. It's a very difficult area.
So I am very upset with this lesion. I am going to finish all 80 pulses. Okay.
Are you planning to use another IVL of bigger?
No. I don't think it will be required. Epicaudal. See, I could take this chance because the left main itself is too good in this case, and the proximal LED is also pretty good. We come back little. Go.
Dr. Akasaka, has any comment about malignant nodule in this particular case on IVUS?
Yes, there are two type of nodular type calcium, right? One is an elapsed and the other one is a simple calcium nodule, right? The calcium nodule is the simple protrusion of the calcium, but the elapsed calcified nodule is a very malignant condition. Anyway, if you put a stent at the site of the calcified nodule, there are lots of protrusion from the nodule to the lumen. It makes a rapid progression of the new calcified nodule. So at the moment, I do not have any good idea to treat the calcified nodule by stenting. In my practice, try to avoid the stenting. Just do the ablation and just drug-coated balloon and wait for 3 months, 6 months. That is my strategy. Are there any good idea if you have?
No, see, calcified nodule, whenever you treat, there is a risk of having the dissection on the opposite side, and then just the bailout procedure where one has to put the stent as well. But then in case the result is fine after drug-eluting balloon, yes, one can go ahead and do it. But then rotablation and IVL is much effect in treating the calcified nodule, and thereafter
why
one can go ahead
the
and
voice
put
is
the
low
stent
here?
across.
Excuse me.
But Akasaka, do you have any prominent calcified nodule in the index case?
In
this particular case?
Calcified lesion and
yes. Generally speaking, the result is poor compared with other condition. Calcified nodule is, that means the elapsed type. There are no good idea. There someone recommended the laser ablation and drug-coated balloon. But still, there are lots of the risk of restenosis.
I think the diagonal is still maintaining itself.
Yeah.
Yeah. And you have good landing zones on both sides.
Now, again prophylactically, I will go in with the guideliner, and now I will push my OCT catheter in.
Yep, it should go now.
This case made us do lot of acrobatics, Samir, not expected out of this case.
That's true. Do you think at the diagonal area there is still some lack of expansion of the vessel?
That is where I am suspecting nodule. We will see.
Yes. By the way, Dr. Akasaka has a great manuscript in Euro intervention about calcification and nodules. I recommend everybody download that. It's free and it's extremely well written, very well, characterizes everything.
Yeah. Okay.
Still more. Epicranial?
Epicranial.
Wow, it has gone.
Pray God it goes in. Yeah.
Yeah.
So it looks like you're advancing it as one system, right?
Yeah.
The wire.
So
catheter,
now I
and
will
that.
pull my guide liner back. Go to epicaudal. Using guide liner again is a stress, I tell you, Samir.
Yes, it could be very traumatic,
We need to
especially in
remove this, huh?
curvatures
Because
like
it
this.
Injection.
So I am removing guide liner. नहीं निकले आप नहीं निकले okay चलो it's okay
बंद नहीं आवा image.
scout just let us see जो तो
बंद करो.
जो तो
Dr. Tejas, it
yeah
seems
should be okay
नहीं आवा.
yeah
you as a highway
Well,
driver
password
is
details
stress
तो
free
बढ़िया
whenever you are doing the PCI.
Yeah.
And not using the belt but having the speed of say 100 miles per hour.
चलो,
So that's
જોઈએ
something great
કેવી આવે છે.
चलो
and commendable.
I don't expect good quality.
it may not be a great image but let us see
ના પણ આમાં જશે જ નહીં જલ્દી.
even with whirling if I can see something we can interpret because the guide liner is giving me problem no professor
Yeah.
No.
Still not a clear image because there are lots of blood. So it might be better to push in the guideline a little bit, cross over the CX. Yeah.
so you think that I should push the guide liner in
Yes. Yes.
yeah selectively Sanjay
Selectively.
it's a
to
good
the
idea
LED. Just
LED.
cross over the LCX.
નહીં તો બધું કાઢવું પડશે
ના અહીંયા સુધી લાઈટ
In such kind of calcium tortuous lesion, which catheter goes in easily, OCT or IVUS
નહીં આવે
catheter?
ગાઈડલાઈન નથી કશું નહીં આવે.
ગાઈડ લાઇનર જ અંદર નાખી દઈએ તો
તો બી નહીં આવે.
આવશે ને
I think,
છેક
I think the
selectively
OCT
કરવું છે
catheter
તો
is a very short rail,
Yeah.
and that sometimes comes
Yes.
as a problem.
That's right.
okay
Yeah. Okay. Yeah.
yeah okay now we are in selectively in LED
પહેલા
જોઈ લો just check it
Just check.
okay
Better.
let us see
yes.
and Sanjay will give a delayed injection because there will be resistance for the catheter to come back so he still now he has started giving no huh so I have to remove it
આટલું કાઢીને જો ને કદાચ ગાઈડલાઈન જેટલું બહાર નીકળે એટલું કાઢો તમારે.
it won't
Dr.
come.
Tejas, can we have a direct injection without guide liner? I think that's
but
going to
you know
help
yeah that's
with
what
good cannulation of the left main.
That's what we are doing.
હવે નહીં નીકળે
નીકળશે નીકળશે.
નથી નીકળે હાલે ધીરે રહીને કાઢ
જેટલું નીકળે એટલું કાઢો.
આવી ગયું બહાર
રેઝિસ્ટન્સ ઓછો.
so we are almost there
We need to cut it.
we can cut it
Yes, look.
I think we will cut the guide liner no problem can you see now or it won't be there let us check it
જોઈ લઈએ જો જાય છે.
જો તો
એક જ મિનિટ બેક બેક વ્યૂ.
yeah just check it
No.
nahi
What's happening?
nahi guide liner if I have to remove everything so I am cutting the guide liner
Oh, okay.
so this is another issue yeah Sanjay so Sanjay is cutting the guide liner very carefully wait બાઉલ આપે સંજય એ કપાઈ ના જાય પેલું નહીં સંજય વી આર નહીં નહીં
I think after we are done, we'll show this method.
Yeah.
Yeah.
Sanjay.
Sanjay, can cameraman demonstrate how
Yeah.
are you cutting and remove the guideliner? That's very fantastic that you have nicely demonstrated use of guideliner
આખું
for
કાઢને
pushing the
ખેંચ બહાર.
balloon, pushing the OCT
કાઢું ધીરે ધીરે
catheter.
બહાર સંજય
આ એક મિનિટ જેટલું નીકળતું એટલું કાઢો ને.
એટલે આ કાઢ્યું પેલું બહાર આવે છે
ઊભા રહો હવે લેટ અહીં recording.
યા બધું બ્લડ નીકળશે
બધું
ના.
અહીંયા છે ને?
હા.
It's okay.
No. So what next? I have to push it again, right? The catheter. So keeping the fingers crossed. Sanjay, this will damage the OCT.
ના, મારું કોણ પેલું ઉપર છે મારું ઉપર છે ને it has
Sanjay
already
is doing a dissection of guideliner.
it has already
Yeah,
done.
it has already. He has already done it,
Yes.
and here we are able to remove it. A little bit. A little bit. Last. Why cameraman should focus here? Doing it. Lovely. Okay, Sanjay, that's more than enough. Oh no. Yeah. Yeah. So almost out.
હવે આપણે નહીં
Now there should not be any resistance. Now go to, yeah, we will show.
OCT ઇમેજ નું પેલું નથી પકડ્યું ને કંઈ
Bubble.
હા કાઢીએ
Now I have to push the OCT catheter a little in. You saw the guideliner has been dissected completely. A little bit remains here, but it should not be in our way.
હે ને ફાઇન
Now go to epicranial. Sanjay.
નહીં પ્રોબ્લેમ નો પ્રોબ્લેમ કશો જ પ્રોબ્લેમ નથી બધું આવી જશે સરસ
I have to push it in.
અચ્છા okay.
That's the problem.
Tejas sir, do you think that 7 French catheter is 6 French catheter here is the causing us a bit of
I don't know.
No, for you.
I don't know because this is the first time we are ever encountering this problem, and this is the on the spot improvisation we are doing.
That's great. I think this case is a typical example of angiography being underestimating the amount of calcium.
Yeah, angiography is has very poor sensitivity, but when angiography shows calcium, it has to be very significant. Wax है संजय.
Yeah, OCT catheter
बस
is
आप लोग
moving
खींचे ही
back.
ऐसे संजय. God. Whatever comes, we will take. I think. ના પણ બહાર જ આવી ગયું છે. Let me go in with this.
ના નહીં જાય ને અહીંયાથી આપણા નડશે સહેજ જ જશે
Wait. Can it come back? Yeah. No.
થોડુંક જશે અહીંયા સુધી જાય ત્યાં સુધી વાંધો નથી આપણે જવા દો વાંધો
જવા દો, ચાલો.
થોડુંક જશે તો વાંધો નથી જવા દો with that
Okay.
yes fine
But now, do we get a good image?
yes it
No,
will
wait.
આવશે guiding
Now, epicaudal. Go to epicaudal. So this is the problem I think we are encountering for the first time.
let me see.
Jo to.
okay it will come
No.
આવશે
Let me give
આવશે.
a little bit curve there. Okay. Go. Take it now.
Yeah, now it's a good position of the
Chalo,
guide
go.
for filling the vessel.
Yeah. Inject. See,
Okay.
he gave a delayed injection.
Great.
Huh?
Yeah, we could get enough image.
still we need one more injection
Yes.
proximal is seen
Yeah, proximal is seen.
We can identify the proximal, right? But
Proximal
this is the distal.
this side.
I think here the 20 cc Leolox syringe would have been more
The
helpful.
20 cc, unfortunately, will not give enough adequate pressure while going in. It's a huge, there is a hematoma there, a big one, yeah.
So here I think we needed some more of a volume rather than a pressure. Pressure is adequate as we got a good
Yeah.
images
Now
proximally.
Now
One
we will
more.
show you what we do. He will inject in advance, very early.
okay
Go. Chal.
Auto calibrator.
Yeah. He is injecting already.
Okay. Great.
Yeah. See, he injected beforehand, before the blue signal starts. And this is a good image in the proximal
Yes.
part.
So first was showing proximal.
Here
This
is
is distal.
distal, right?
Yes.
And then,
Complete demolition of the area.
right.
So let us see the distal one first.
This is
Yes.
distal.
This is the distal one.
Okay, can I back?
Can we enlarge the OCT image, please?
Yes, Raj.
I am removing now. Huh?
Can you see the OCT image?
Law, God.
Here is the distal part.
Yes, we could see it very well.
Okay,
yeah.
this
Thank you.
is the distal reference, right?
Yes, that looks like the reference
Okay,
segment.
so the diameter should be around 3.
Yep.
Yep. And then move slowly to the proximal side. Here is a, yes, you can identify the dissection at the 12 o'clock, right? And then
Very good.
here is the distal calcium, right? You can identify the calcium at the 3 to 6 o'clock.
Yep.
And dissection here, right?
Yep.
Right, and then goes slowly to the proximal site. Here we cannot identify any calcium, but you can identify yes, dissection here.
Stand touch kar diye.
So comes to the proximal site.
आप एक मिनट bubble का चलो
You think
Here might be the nodular calcium, right?
Yes.
Go to AP cranial.
From 12 to 3 o'clock.
Rajni
And
ko
make a
saame.
crack at
Sheath
the
muki
3 o'clock. But this side is a simple the dissection of the opposite side of the nodular calcium, right?
There is, Professor Akasaka, why
Yes.
don't you explain what is the difference between nodular calcium and calcific nodule?
Okay. Calcium nodule is, generally speaking, elapsed type, right? Calcium nodule is actually containing the red blood cell and the fibrin or something. So it is in a very worse condition, and nodular calcium is very simple calcium just
3.5 by
protruding
12,
to the
18.
lumen.
ना 3 node मूलते नीचे
And so it looks like nodular calcium is the more malignant one, right?
That's right.
3
That's
by
right.
18 no giants alpine.
Calcified
Pancholy
nodule is much malignant. Nodular calcium is very simple calcium. Right? Here is between the proximal and distal portion, right? Nearly yes, 180-degree calcium from 9 to 3 o'clock. Right?
Can we enlarge the OCT image, please?
Very thick, right?
Yeah.
And here also the
open,
this
sir.
is the proximal site. Yeah, we can identify the calcium from yes 9 to 1 o'clock, right?
Yes.
Yeah.
Is there a hematoma on the other side?
Yes, I think there are dissection in the proximal site. Here might be the dissection. Still lots of calcium around 9 to 3 o'clock. Very, very thick, right? And this is a proximal site. We cannot identify any clear image, but there's still lots of calcium around this site from 3 to 9 o'clock.
Can we have the second image where the proximal part is more
Okay,
clear?
okay, try to.
And Akasaka, have we come across the diagonal origin in this first
Okay,
image?
okay, all right.
Sanjay,
I think nodule was proximal to that diagonal, though it is not.
Yes, I think so. I agree. Yes.
ले लिए
This is a proximal site image,
Another guideliner.
right?
So, Dr. Tejas, are you going to pre-dilate the lesion before putting a
No,
stent?
no.
Okay.
I am going to put another guideliner and fix the lesions very quickly now.
Okay.
Because with this heavy calcium, my choice will be the stent with a very high radial strength.
Yes.
And the radial strength does not, work well with tortuosity. So,
Yes.
unfortunately, I might have to struggle a little bit. I am taking Giants Alpine with guideliner. I wish I am able to go in.
Size?
First I am going to go distally 3 by 18 and then I will work on the upper side.
Okay. So
Because here I will never think of taking any long stent.
yes.
No, no long stent.
So plan is to do overlap after that diagonal.
We will see, yeah,
Okay, that's
yeah,
very
definitely.
important.
Yes, yes.
I will try to compress, that distal plaque, flap, and then I will put a, bigger diameter stent there.
There is some myocardial bridge also.
Yes,
yes,
yeah.
Dissection.
So makes it a little bit
After
less than,
dissection, yes.
yeah, just a little bit less than ideal landing zone.
Epicaudal. Epicaudal. હવે બહુ કેરફુલ રહે છે સંજય.
Dr. Akasaka,
Fluid
can you
ચાલુ કરો.
demonstrate the effectiveness of IVL and NC balloon in calcified lesion modification? Any calcium fracture? We couldn't see calcified nodule having any fracture or discontinuation.
Nodular type of calcium, it might be very difficult to make a crack if you use any kind of modality, right? Such as scoring balloon or cutting balloon or IVL as well, right?
Perfect.
As you can see here, the very thick calcium, more than 1,000 micrometer, it might be very difficult to make a crack.
Epicranial?
So
Go to
just if
epicranial.
you try to put a stent, the vessel expand the opposite side of the nodular calcium.
Oh, Pancholy.
Yeah.
We are there.
Dr. Akasaka, can we go to that distal one OCT at 20? I think there was a calcified
Okay.
nodule
This
and
is a
there was
good
a
area.
fracture at the base of the nodule. I'm not
Yeah.
sure. Can you
Looks good.
show us the cross-sectional image, B mode at 20?
નીચે કરી દેવું છે.
Okay. Yes, this is
Bridge
the
है.
distal portion, right?
That is a
Yeah,
bridge.
20.
As I told you, here is the difference area, right?
લે.
The diameter is about 3, right?
જો.
Yes.
And
Okay.
this is a small calcium, and then
Can we come at 20?
જા.
here
15.
might be the
20, yeah.
nodular type.
Can you? So this is what we have also observed, that if we use IVL for calcified nodule, the most common
Deflect.
site of fracture is the base of the
whisper.
nodule, and in
guideliner
fact
પાછું
post
લેવું
IVL
પડશે
nodule come
મારે.
more inside the lumen,
કરીશું?
but it
થોડા
does
એવા દે,
pulverize the
standard
calcium and
એ જ કહું છું.
do get a good MSAs. But
Guideliner
the
સુધી
Yeah.
usual practice is
Ah.
pre-dilate
If the IVL very useful, we
Yeah,
can
because
expect
whisper.
the fracture at the
Okay,
very thick
deflect.
portion
Fine.
about the 12 o'clock in
લાંબો લઈ
this
લેવો છે
image,
ને?
right?
Yes.
However, we cannot identify
We can
any
take
fracture.
another guideliner ત્યાં સુધી.
Only I think some dissection at the
શું
edge of the calcium
કરી
by
કાઢા
its
અંદર,
cross-sectional area, and we cannot identify any image because of the shadow of the wire here, right? So might be no fracture.
Can we go a bit
3.5
distal, please?
લેવો પડશે.
This is out
Yeah.
here.
ચાલ આ જોઈ લઈએ.
Yeah, small amount of fracture here.
So this is the usual picture that we have
ventricularized,
seen by using IVL on calcified nodule.
Yeah.
And now
બરાબર
the
છે.
idea is to see how stent gets
નીચે જે
expanded
હોય એની
and
ચિંતા
what are the
નથી કરવી.
MSAs and
હવે
the
length
spherical
કેટલી
index
લઈશું?
that we'll get at this area.
Yeah,
Post
કે છેક
PCI
સુધી
image
જવું
will
છે.
show us.
But I think if you dilate using a bigger balloon, it might be very difficult to make
3.5.
a much more
3.5,
crack because,
28.
as you know, here
Alpine.
is the very thick calcium, more than 1 millimeter, right? Here, I think from here to here, right, 12 to 3 o'clock, you can identify nodular calcium. So
Yes.
if we put a stent, the vessel dilate this normal portion, right? So too much dilatation using a non-compliant balloon, higher pressure may have the risk of perforation. Therefore, we have to accept some under expansion, right?
Dr. Akasaka, could we demonstrate 360-degree arc of calcification in OCT at any point?
I try to. Here also the nearly 180-degree calcium, and we cannot identify any fracture at this portion, right?
Right, yeah,
And
that's,
only a dissection at the edge of the calcium, and right.
despite IVL, that is very difficult calcium
Yeah,
looks like.
very difficult.
And this is the point where the nodule is
Yeah.
getting protruded and what sort of therapy you are given because it's dissection on the opposite side.
If there are nodular calcium and if there are no dissection, and we are always think about the wire position by OCT, and in this case wire is just around the calcium site. Therefore, low tabulator or orbital atherectomy may make some modification.
Does the laser have got any impact on this this kind of calcium?
So always wire is just beside near the calcium portion. So some of idea is small size of rotabulator might be helpful, but in this case very complex here. Yes. So I'm not sure that really rotabulator or orbital atherectomy is effective or not. As you know, that if circular calcium and very concentric calcium, it's quite safe to use low tabulator or orbital atherectomy. But in an eccentric yes, calcium, we always take into account about the wire bias.
Does the laser effective in such cases?
Yeah, I think the wire always very close to the calcium here, right? So some modification can be expected, right?
So they say that as far as laser is concerned, it's not useful in heavily calcified lesion, only in moderate calcified lesions. So the recommendation also is there that if you have got a tight lesion, you are not able to cross with anything, balloon or non-crossable lesion, and you are not able to cross with the rota wire, there the laser can make a path even if it is fibrocalcific lesion. But heavily calcified lesion, primarily laser has not been shown to be very effective.
But in this non-circular expansion in LED, how much area to be
11%?
on OCT?
So till now we have got evidence that outcome will depend upon MSA. We are not sure about that spherical index or eccentricity because of calcium. Now we'll see after
Getting
that
stuck there,
stent placement. We'll see that stent will not be that circular.
They might have to accept it.
It has come.
But
Just see,
they say that if you don't have a circular laminar flow, there may be more chances of ISR.
જોઈ લો
હા જોઈ લઈએ એટલે એમને મત જોઈ લો તમે પાછા હતા ત્યાં ના નહીં વાંધો આવે should be okay.
I just said so. Go, go, no problem. This is good.
Jao AP caudal
10,
12, 14,
Are you
15,
stenting proximally first?
18,
18,
Is for this seconds.
20.
20.
Deflate.
Okay.
That's it. આમાં બહુ
No, અડી ગયા છે strength. We have touched.
So what is the size of proximal stent you have taken, sir?
3.5 by 28 Giants Alpine. It gave me lot of difficulty to pull it back. Believe me. શું કરીશ કે આનું પકડ.
Yeah, I think, but the alignment is good. You have overlap and you stent it till the proximal. So
Chalo, everybody do the prayer. I want a good result here.
yep.
It's nice.
Just check it. Okay,
Fine.
go to AP cranial. Now I will remove. I am very confident.
It looks good. Maybe needs to be post dilated in the middle a little bit.
Let me see. Wire.
Yeah.
Okay, check it.
Fine.
See, the diagonal is still there, huh?
Yes, it is.
So no problem.
The distal end of the distal stent. What do you
That
think?
that was the breach at that time Bhupesh pointed out. We will simply check it now using
Nitro.
this thing OCT.
Nitro here.
Sanjay is giving 500 mics of nitro.
So Tejas sir,
Yeah.
so what's your opinion regarding for our young cardiologists, like this size of diagonal, Now you have got experience. You knew right from the beginning.
If I see
Yeah.
this was not a small diagonal, this
Yes.
was a moderate size. If I see a small diagonal which is 2 millimeter or less, and even if it is diseased, I don't care, because then it does not qualify for bifurcation.
Yes.
If it's this size, and if I see a very clean or almost clean ostium, again I am not much worried about it.
At this angle.
Yeah.
With this angle, yeah.
Yeah.
Guiding circle.
Yeah, go to epicaudal, and now let us, last injection I will do is OCT, because the other case is ready. Yeah. So,
Dr. Tejas, will you
Karina,
like to
please.
dilate it with the NC balloon as per the reference with the previous OCT examination? And then to have the OCT.
areocranial.
Because the proximal size was around 4.
So how many of you thought that the case will be over within half an hour? I thought that it should be over within 45 minutes.
Superb.
It took long time, huh?
I think that's a typical character of calcified lesion.
That has gone.
Huh?
No, bridge clear.
That is a bridge. You can see
And
in
spasm has
areocranial. Spasm has gone. Now get me OCT. I really don't want to do anything now. One OCT and we are out.
The distal looks very good. Yeah, I think
It was spasm.
It was spasm.
it was spasm.
And by and large, distal to lesion immediately, if you see spasm, it is dissection 90% of the time and not the spasm, which we many times misinterpreted, in a pre-imaging era and created problems for the patient.
In the IVUS, the proximal LAD was 4.25. So whether to post dilate with a 4O balloon or just to
The Jayesh, it will be very clear with this
OCT.
OCT. OCT should go anyway. Oh no. If it doesn't go, I will use IVUS. It will go. In calcium, the IVUS works better. No. Get me IVUS. Get me IVUS.
Yeah, I think it is that short rail of the
That's
OCT
right.
catheter.
That's right.
Yeah.
In the panel discussion, we have one case which I will show, how the calcium can be an enemy at times for OCT imaging. Although OCT imaging is a friend to calcium cardiologists as far as calcium management is concerned.
That is true.
So Tejas sir, we are coming to end of this case. After so much of effort, do you suggest or think that, or you recommend for us or for the young cardiologists to think of, upfront rota in this case to make a bit easier?
Rota, I don't know how it will make this case easier. I really don't know, Ankush.
So the struggle that
Because tortuosity can create problem, and you have to go on changing the burr, and after changing the burr, if somehow, if you use a higher burr and lot of calcium goes distally in this case, then also there is a problem.
slow flow and all.
Yeah. Where are we?
No, we are
I think here bend is causing the problem.
Use guideliner.
હવે નથી કરવું.
આમાં contrast નથી આપવાનો.
Yeah. Yeah, he has started, right? Russell? He has started, kept it on, so the vibrations. Now go to epicranial and let me see where is the lens.
Does the trackability divide Phillips IVUS catheter and this Boston makes a difference because of tip or anything?
guideliner.
Look, take a guide.
Boston has got a better, trackability, and moreover that
Out.
and my personal
Go to
opinion
epicaudal.
that visibility wise and their HT IVUS catheter, it's quite good as compared to that Phillips one.
So last attempt I am doing with a guideliner, I will push my IVUS catheter in and take a final view.
So is it not going even with the wire if you're pushing it with the
Yeah,
wire?
yeah, that's right. So this is a bad resilient calcium. sitting on a couple of tortuosities.
Yes.
Dr. Prasad, any comments from you?
Yeah,
Well,
Abhi, why are you so quiet?
I'll go back to my approach would have been different on this case. So I think rotablation would have been the way to go here. I would go small burr and size it up, 125, go to 1.5, and then lots of NC.
Okay.
And I may have, we could have added the IVL at the end if you found it areas. But again, it's easy to sit here and comment on those things. But I think there's a role here for rotablation.
Samir, what do you think?
Yeah, I think, a 125 bar might have been safe with those bends, but, like Abhi said, it's easy to be a Monday morning quarterback,
Exactly.
Going forward.
This is an incredibly difficult case, and I mean, credit to you, Tejas. So, especially about that diagonal, very confident, I like that.
Confidence, Abhi, confidence emerges either out of experience or out of ignorance. Now it is your call about me. So, no, I was pretty confident about it. I'm just kidding.
One thing is that just last one month back, just we finished the procedure and the IVUS catheter. Of course, we have used the reused one, and that catheter stuck and stent got distorted and all. So sometime vigorous attempt to do imaging in the.
I agree.
Yeah.
I absolutely agree. So that's what I'm not going to do in that case.
That ways we have to be very careful in calcified lesion, and that too if you have already placed overlapping stent. If the catheter got stuck and you make an effort to pull the catheter.
Here, I don't think I will try much. See, let me just remove.
Can we predilate with NC 3.5 or 40
It's now
doing imaging?
No, it's going inside, Pinto, but then it has progressed further a little bit. Are we halfway?
No, proximal part.
Yes, I think if you put the guide liner and bring the guide back a little, you might get the contralateral aortic wall.
So this is the principle of physics you want me to use.
It might work. Sometimes it does. It's these pseudo-lusorias are almost as bad.
Can
as
you start?
lussoria.
Check the connection. So, detect it's not working there.
Not working.
क्या? Motor को? हाँ. It's
Connected.
it's not coming. So it's probably the catheter has gone haywire. So it's okay. I think this is the time when the nature is telling us not to do anything in this case. Let me check the result.
You think OCT through the guide liner might work?
No, but again we have to cut.
I think
then OCT image will not be coming. I'm sorry for that, but this is all about it. Ultimately,
Can we attempt one attempt with that guide liner plus OCT guide
Oh,
liner?
OCT again we have to cut and all those things, and
No, guide liner, keep the guide liner there inside. That OCT
but then injection may not be. Now let me see the result.
Injection was not possible
Scout.
because it is a 6 French guiding.
Scout.
So, do you think 7 French guide would have been better?
Yes.
Yeah, I think here we underestimated this calcium and the LAD. It would have helped us. Go to AP cranial.
It's fine.
Whatever, we feel, I am going to quit now. That's it. Enough. Go to RAO cranial and RAO caudal.
So Tejas, would you finish off with post-dilation given that we couldn't image? Just
I
to be
think
sure?
we should use do the post dilatation as we have seen that the proximal LAD was bigger. It
I
was
tell
4.
you, Ankush, here you try to do post dilatation and high pressure and all those. We have a good nidus for creating a perforation and everything will be messed up. We have a good lumen, and you can see the stand struts, and the character of the stand struts on angio, they almost look hugging to the wall or whatever, rather than giving some idea, because in calcified artery you have an idea of two separate linear sort of opacities seen when the things are not done well. So trust my judgment.
You are absolutely right. Angiographically fantastic result. All small branches,
Go to
septals,
RAO
diagonals,
caudal.
they are flowing. The blush is good. Angiographically it's fantastic. You are absolutely right.
Better is enemy of good.
Yes.
So we will be going to the next case within 2 minutes. I am coming. Again, I thought this was an easy case and I have kept a more complicated case there, but we will work it out, no problem. Just within 2 minutes,